Good afternoon, everybody. We have Dr. Gish with us. He's just he's with us now. Good afternoon, Bob. Again, good afternoon, everybody. Thank you for joining us. It's good morning to Bob. It's 7 o'clock in the morning in the States where Bob is. So, I
will love your leave, yeah?
I love you. Right, thank you, Alan.
I will see you at the end of the session.
Okay, we've got people.
Thanks very much.
Okay, thanks, Alan. We've got people in the background working away doing the technical things. Now I've sent you some of the questions I managed to get, Bob, which is great. And I think we last saw you in September last year, if I remember, and you mentioned one or two things about diet and food, and I was very interested, and we didn't have time to go into it. As we've got time today, I'm going to pick your brains. Is that okay?
Great. Glad to be here. Thank you.
Okay. Sorry, I've got a tablet here and it's talking to me, and I don't know why it's talking to me. Never mind. Right. Now, I'll start with the questions, and thank you, everybody. If you want to send them in, we'll get to as many as possible. Those that we don't, then we'll do for next week. And hello and welcome, Dr. Gish. Thank you for joining us today. That's our head of education and development, who took over from Robert. That's young Chris. He's not so young, but we call him young Chris because he's younger than Robert. So welcome everybody again today, and I'm going to get started. Now, my understanding is, Bob, that OCA is not licensed in the States. Is that correct?
OCA is licensed in the United States for primary biliary cholangitis, but they did not receive the license for treating fatty liver.
Right. Okay. That's really helpful to know. So this question then is pretty bad. I was a bit worried about this first one. So this person says, after seeing my consultant last week, I can choose between OCA and bezafibrate on the assumption, of course, they're on urso. How can I make a decision? Oh, well,
that's a great question. So,
isn't it?
Bezafibrate, and in the US and other places, there's also fenofibrate. Those are two choices that are out there with clinical information, but they don't have a label for treating PBC. So patients, providers have to go through the thought process. Should I use something that has a label, that has very large randomized prospective studies and are licensed, or use something off-label? So that's one part of the decision. Also, if people have a lot of problems with itching, you have to take in mind the clinical data that with bezafibrate or fenofibrate, a little bit less data, but itching may actually improve. With OCA, you're not going to get an improvement in itching, and then a subset of patients have worsening of itching, and some have so much itching that they have to stop or dose reduce or dose interrupt the OCA. So if itching is a really, really big problem, bezafibrate may be a choice to consider.
Okay, so just give you a bit of background in case you wanted to add to this. She's only been diagnosed since October last year, and her ALP, alkaline phosphatase, was 112. Her gamma GT was 41, bilirubin 15, ALT 24, and she knows nothing about PBC, so she's very appreciative of any information that you could give. She does not have any symptoms either, so that's quite interesting, just in relation to what you're saying about the itch and OCA.
So I think somebody who's just entering the PBC world, had a recent diagnosis, I think the first question that they ask themselves and they ask their provider, importantly, is, what's the stage of my disease? What's happening in the liver? How much damage is there? There's a small subset of PBC patients who, present with really mild disease or no significant liver disease. And the best way to assess that is with non-invasive testing. Obviously, a biopsy gives you a lot of information, but it's an invasive test. So talk to the providers about what's the stage, taking pictures of the liver with ultrasound, using elastography with the machine like EchoSense, the FibroScan, and then doing something like the APRI or FIB4. Then I really ask the patients, do they want to know what the future looks like? And that's where the UK PBC score or the GLOBE study, those calculations leaders can look out, 5, 10, 15 years and say, here's the chance, the probability of something happening. People want to know where they are.
Yeah.
What do you think?
Yeah, no, I agree with you. I think this person really should have said to her consultant, what do you think? Given that he will know where she is in her journey. Although she's just been diagnosed in October, that doesn't mean to say that she hasn't had it many years. So if you're listening, and I hope you are listening, or maybe you're listening later on, you've heard what Bob has had to say, and I go back and discuss it with your consultant, whom I've known many years, and he'll be very open, I am sure. And never be afraid to ask questions. And if you don't understand, that's okay not to understand. How could you? We're not doctors, so don't ever be nervous of that. So I'm going. Just on those results that I gave you, this person is a bit confused about these results. Now, to me as a layman, they read perfectly okay. I don't know how the values in America, if they're different from ours. But an ALP of 112, gamma GT of 41, bilirubin of 15, an ALT of 24 is not alarming, is it?
Well, it's very clear that the level of alkaline phosphatase and GGT, the higher the level, the worse the prognosis, the higher the chance of progressing, the higher the chance of having more severe disease in the future. So these values you gave me are very close to what we call normal or what we call healthy. I like the GGT to be under 35. And I really like it when the alkaline phosphatase is under 85, but under 115 is a really good number. So if you're 115 or 117 or 120, that's pretty close to normal. So I would be encouraged by those numbers, but still want to know what's going on in the liver. And also, people might have fatty liver. Also, we need to make sure people get worked up for fatty liver. They're not drinking alcohol, because alcohol can obviously flare things up. The AST and ALT are nice also because they tell you if there's a component of the autoimmune syndrome or an overlap with autoimmune hepatitis. And that ALT value you gave me was in the healthy range. That was nice. Those are good numbers. Good numbers meaning they're low. They're close to normal.
Yeah. Not bad set of numbers is really what we're saying. Okay, thanks, Bob. So this person says, there's a bit background. My AMA test has come back positive for PBC, okay? Yet my ultrasound from my liver was normal. I do have a few symptoms, itching, falling asleep, aching all over, constantly bloated, even without eating. Surely I would have an abnormal liver if that is the case. I'm not sure I understand what's happening. And this is, I think, a bit of a classic question. I think a lot of people, Bob, have the understanding the worse your symptoms are, the worse the disease is. So this is really quite a good question, isn't it?
And don't you agree, Collette, that the symptoms are really disconnected from how bad the liver disease is?
Absolutely. Yeah. It doesn't, having severe symptoms doesn't mean you have severe PBC. And I can't give the technical details for that. But, somebody like me, I'm celebrating 28 years this month with PBC. And, I have my tired days, my this, my that, but I get out on my bike and I can do things and live a relatively, good life. And Bob will testify, we've climbed some high hills, haven't we, Bob, when you came over to Edinburgh? And it comes and goes, but you have to be clear, it's not indicative of severe disease, to my knowledge.
I agree. And I look at, PBC as like a big picture. It's like a global picture of a person's health state. And they could consider it severe PBC if they have severe fatigue, but that doesn't mean there's severe liver disease.
Yeah.
So PBC is a disease of the entire body, and liver is a focus, but the liver part can be mild, yet the itching can be terrible, or the fatigue can be terrible, or maybe thinking, what we call cognitive, can also be poor. And that is their world, and it's not. It shouldn't be something, or it shouldn't be something else. It is what it is. Then we just start trying to make those parts improve.
Yeah, that's absolutely right. Yeah, but I think it's helpful for people to know, because it takes a bit of that fear away. Because with fear, that can affect your quality of life, and it takes hold. And, we're all normal, and that's what happens with people when they get diagnosed with something like PBC. But if whoever this person is, if you want to give me a reading, I'm happy chat with you. But I'd be encouraged by what you've been told. The next question is, should I declare I have PBC when applying for travel insurance? My goodness me, let me tell you that insurance companies will do anything not to pay out. Anything. You always declare whatever condition you have. Always.
Agreed.
I think the States are a bit more litigious than what we are here in this country. But you declare everything. You've got high blood pressure, PBC, everything. Do not miss something out on the basis you think you're going to be all right, because you just don't know. It could well be you fall, you break a couple of metatarsals or something, but you haven't told them about PBC. They're not going to pay out for whatever you were claiming. Would you agree with that, Bob?
I would, and people should be aware that most travel insurances exclude coronavirus. So, you think, oh, I'm going to get travel insurance if I get sick. The insurance will cover me for corona, or not going if I get corona. Mm-hmm. And most won't cover that at all. So just be aware.
Yeah, absolutely. Don't trust insurance companies. Look at the small print. If you don't know, ask somebody. Phone us at the office. We'll guide you through it. And now, should a 70 years young woman be worried about? Oh no, this is a good question actually, and this is embarrassing for people. Should she be worried about anal mucus, discharge, no blood? She first complained to the doctor in 2018. She had a sigmoidoscopy, which is good, and a colonoscopy previous to COVID, but both proved negative. I find it very disconcerting. I cannot go for a walk without wearing a pad. That's quite distressing. Now, this just came in late last night, Bob, so you won't have a note of this.
So again, that they're having trouble with gastrointestinal bleeding, but
no, it's an anal mucus discharge with no blood. No blood. Sigmoidoscopy, colonoscopy, clear. But she has to wear a pad when she's out, and she's finding this distressing, and I would imagine embarrassing too.
I think that one question I always ask when they did the sigmoid or colon, did they do biopsies? And if they didn't, they may have missed a microscopic colitis. If it could look normal, but it can show up on a biopsy. Mm-hmm. So that would be my first question for that.
Okay. Is there any other condition that can cause this distressing symptom that you're aware of? And it probably won't be PBC, and it's not your area, but it's worth a punt.
Yeah, I think that's the most common, the microscopic colitis. There's other types of colitis that also can be picked up by biopsy that can't be seen with a camera. So I would go back to the gastro, and definitely one way to help that is to add more fiber to your diet. And that would be, Metamucil. I don't know what is available in the UK, but I try to get all my patients on fiber supplements. It's really, really healthy for cholesterol, itching, the biome, everything. So fiber is a great choice.
Bob, I wasn't aware that fiber could help itching and everything else. Maybe when you've got a spare wee half hour, would you write us a wee article about that, please? And we'll put it in our bare facts, because that's quite new knowledge to me, which I'm very keen to share. Would you mind?
Yeah, I'd be glad to talk about fiber. That's what you're asking, right?
Yeah. If you could maybe, I don't know, 2A4, 1A4, we put some graphics in, that would be really, really helpful. Thank you. So somebody's asking, are there any interesting developments in clinical trials going on at present? Everything's been put on hold because of COVID, but there's quite a lot going on. I know David Jones has just launched, they're doing brain fog. They're working on, what, have you got anything going over there, Bob?
Well, there's a Salaldapar study that's going on right now. So I think that's encouraging. Intercept does have it's a type of license to develop bezafibrate, even though bezafibrate's generic. But to bring it in and get an indication for PBC, and they're looking at it in combination with OCA. So I think one thing for people to really discuss is what's this new target for alkaline phosphatase that people really should be trying to get their alkaline phosphatase normal. A patient that I saw in clinic yesterday has PBC, has cirrhosis, and she's on triple therapy. So urso, she had maybe a 20% decrease in her alkaline phosphatase. On OCA, she had another 50% decrease in her alkaline phosphatase, but was still running around 170 or 180. We added fenofibrate, and the alkaline phosphatase now is around 80. And I've been taking care of her, I think, for 10 years. And her liver disease is not progressing. And in fact, I think it might have gotten a little bit better. Her cirrhosis might have improved. So triple therapy, normal alkaline phosphatase, that's a direction that we're going in practice, but we need clinical trials to help support that.
Yeah, I know I've heard about this triple therapy, and there's quite a bit of excitement around it. I was speaking with the Intercept boys this week, and I know Chris has been talking to quite a few people in the background, and this is really exciting. And I think it's worth saying to people, we're not forcing you to do anything, but if you're offered opportunity to become part of our clinical trial, do think about it seriously. If you're not sure, make a list of questions and ask the people who are involved in the trial. They normally would pay your travel expenses and all sorts of things, but don't be afraid to ask questions. It's really important. But it's, in the olden days, there was hardly any trials, but I'm quite excited about what here's going on, Bob. I think there's a lot of things coming to the fore. Would you not agree with that?
I'm very excited. And I think with triple therapy or new combinations or newer medicines and this new model of getting alkaline phosphatase normal, the need for transplant is going to go down even further. I have a question, Collette, on your website and also the US website, PBCers, are clinical trials there listed all the time? Can a patient go to those websites and get information?
Yeah, when we get information, we put it up. We also put it in paper form in our bare facts, and we've got 2 adverts going in, one from Cara and one from Simibae. I think Simibae solidipar. So yeah, we try and keep all those things updated. And we do. And we actually ask the pharma companies to help them towards the cost of the website or the bare facts, because these things cost us money. We don't give government funding, so we do say to them, to contribute towards the foundation. I think that's a fair and reasonable thing to do. But just so as everybody out there knows, we're not owned by pharma by any means. We rely on voluntary contributions and legacies and things. But pharma, we do ask pharma to contribute. I think that's right and proper. Now I've got something on the screen here by Livia. Hi, Collette, Dr. Gish. I'm 47, Irish, and newly diagnosed with PBC yesterday. Oh my goodness! You must be feeling absolutely turmoil. Current alkaline phosphatase level 257. Okay, positive AMA, raised ALT at 74, AST 47. Thankfully, I have none of the usual symptoms of PBC and hopefully an early diagnosis. Does this mean there's little known liver damage? Are there any scans that should be done to confirm? I do have dry eyes and chronic lower back pain. And recently some discomfort in the upper right quadrant and feels like a stitch. My ESR results is 39. I'm not quite sure what ESR is. And when I can't pronounce that next word, Bob, can you see it on the screen?
Eosinophils.
That sounds good. Results of 0.61 are the results of concern with lower back pain and linked to PBC. Before I let you answer the PBC, I'm going to say to you, to Olivia, and everybody out there, if anybody's got lower back pain or anything out of the ordinary with PBC, and you'll see from our information what is ordinary and what isn't, always mention it to your doctor, because you can get lower back pain for a number of reasons, a huge number of reasons. So don't discount something because we can't account for it. So make sure you mention it, and any change, just mention it with your doctor. So there you go. There's a bit of a question there. These results, Bob. But how I think there's more to this actually. She's coming further down. Gastroenterologist gastroenterologist consultant advised further blood stool any virus affecting the liver. Good. What are these tests and what viruses need to be ruled out? Well, being advised that I can get an urso. How long can it take before I know it's working?
Well, a lot of questions there. So let's break this down if that's okay, Collette.
Yeah, sure. You got it there on the screen. Can you see it, Bob?
Yes, I sure can.
Okay.
And the whole question about scans comes back to the previous person asking about an ultrasound. And everybody who has PBC should get a full upper abdominal ultrasound. And they should ask their provider or ask the technician or radiologist to measure the spleen size and portal vein diameter. These are ways of deciding or determining how much scar tissue there is and if there's what's called portal hypertension, where a person might be developing varices. The spleen should be less than 12 centimeters. The portal vein should be less than 12 millimeters. And it's really nice to do this because we're trying to avoid biopsies. We're trying to avoid endoscopies. So smaller spleen is better prognosis, smaller portal vein, better prognosis. And then we talk about elastography, and there's a number of machines that can measure the stiffness of the liver to get what's called a KPA. There's two machines out there now. There's the FibroScan and another machine called VeloCure that can measure how much fat is in the liver through something called CAP. So I always like to know stiffness, KPA, and like to know how much fat with the CAP score, CAP score, which is really, really nice. Dry eyes is very important. Every PBC patient should see an eye doctor once a year and check for how much tear production they have. Same thing for the mouth, right? The eyes dry up, the mouth can be dry, and a dental exam twice a year with dental cleaning is really important. Do you agree with all those points, Collette?
100%. I would go on to say, I don't know where this person is, and they do mention dry eyes, etc. In this country, dry eyes, dry mouth, you go to rheumatologists, which I see they are going to. Now, this next bit's important. You have dry eyes and dry mouth. It may show you don't have Sjogren's, but you treat it all the same. Do not leave your eyes to stay dry. You can get great drops these days, particularly the oil-based ones. They're very, very good. Because every time you blink, that fluid is cleaning your eye, but you don't have or may not have much of that fluid. You'll have tears, or if you stand out in the wind, but this is a different set of tears. So do treat it, even though they might say you don't have it. And your mouth, this is really important. Mouth hygiene is very, very important. Please do not use chemical-based mouthwashes because they dry out your mouth. The chemicals change the chemicals in your mouth. They stain your teeth and they distort the taste of your food. Please just use salt and water after you've cleaned your teeth. And ask your dentist what you can, should it be chewing gum or something to stimulate a bit of saliva or sprays. There's a number of things to try. But even if you're not diagnosed with Sjogren's, please treat these symptoms. It's important.
Great points. So the next question had to do with the eosinophils and ESR. So the SED rate, I usually don't check an ESR. I check something called the C-reactive protein, but both of these tests have to do with how much inflammation's in the body, and PBC is an inflammatory disease.
Yeah.
So eosinophils, I don't think that's a direct connection to PBC. I don't know if you've seen that, Collette, from any other patients, that question, but to me, that indicates maybe an allergy.
It seems to me reading this, Bob, if I was this person, I'd be very, very pleased. You're getting a gold star attention here. I don't know what country you're in, but they are leaving no stone unturned, and they really are doing everything that I can see that's available to test. Because sometimes with PBC, we do get other things like Sjogren's or thyroid or rheumatoid conditions, so that you're going to see a rheumatologist. So they will be looking at all these inflammatory markers and doing the test. And in this country, when you go to a rheumatologist, you're automatically given a chest x-ray, read, blood taken and what have you. So I'd be very pleased if I were you. And this person also mentions about naproxen to help with pain. Is this okay with PBC? Again, it depends on what other medications you're taking. But do you know, if you're ever in any doubt, the most underused professional, I think, in the world are pharmacists, chemists, and we have them on tap. So if you can't get a hold of your medical team who's looking after your PBC, there's no harm in asking your pharmacist, because these are very clever, highly trained people. Would you agree with that, Bob?
Yeah, so I went to pharmacy school before I went to medical school.
Well, you've got a double degrees then.
I love it. It was a great education. I agree with you. And pharmacists now throughout the world are getting much more respect, much more involvement. Part of it has to do with the shortage of healthcare providers, and the coronavirus has amplified that, of course. It's also amplified how important pharmacists are in trying to, crush an epidemic or pandemic that we have. So pharmacists front and center. Totally agree.
Yeah, good. Do you think we've kind of covered everything? And that was quite lengthy, but Livia, more than happy to speak with you on the telephone, myself or one of the team. There's lots of information we have there for you. Maybe you want to digest it over the weekend and give me a wee ring next week. And if you've got more questions, you can bring them next Thursday. We've got these running for the next few months. We've got a great team of doctors here. So would you feel comfortable that we've covered all this, Bob, what Livia has put on the screen?
Well, she asked about urso and how you assess the response.
It's 6 months, isn't it? 6 months of taking urso?
Yeah, but at 3 months, you should see it change. You'll see in urso trials, you'll see in the OCA trials that there's a prompt decrease in liver enzymes, alkaline phosphatase specifically, within 90 days. So if in 90 days the alk phos hasn't changed, I'm going to say there's a problem, and you're going to already be thinking, okay, we'll look again at 6 months. That's fine. But by 6 months, I'm going to be ready to add another medication. So 3 and 6 months, double assessment, and then get ready to make a move. Don't wait a year.
Yeah, right. Okay, fair dues. She goes on to say, sorry, the screen, my screen keeps moving. I'm working on very old-fashioned equipment. So she goes on, PBC, Sjogren's, joint, muscle pain, etc. Well, the pain can come from either or both. But let's wait till you get your rheumatology assessment. And you are saying you've got localized pain in the lower back hips. Greater pain the right side of the lower back. Again, it may or may not. It may well be you need to see a physio, and that's another underrated. I think. What's it they say about physios? Doctors keep me alive. Physios make life worth living. If you don't call them physiotherapists, you call them what do they call them in the States? Physio something.
They're physical therapists. That's
physical therapists. Yeah, you've got Brad and Bob who are online on Google. 2 American physical therapists. They're fantastic. But come and speak to that. She goes on to say she's in Glasgow, so she's only 45 miles from me. Keep in touch with me, Livia, and there's a lot going on there. And it might just need slicing up a bit, but and don't ever apologise for the questions as well. But keep in touch and good luck. You're okay. You're in Glasgow. You're all right. So Caroline says, very interested to hear about the triple therapy. I currently take urso with alkaline phosphate 180. As there is no drug therapy for fatigue, could a reduced alkaline phosphate help with the fatigue as well as other benefits of less liver damage? You're welcome, Livia. It's a brilliant question. I mean, fatigue is the holy grail, isn't it?
And I think that alkaline phosphatase levels don't relate to fatigue very well. They kind of move independently. Yeah. And you heard the information about wanting to get everybody's alkaline phosphatase under 115, but adding a third medicine, there's always a risk benefit that has to be balanced. And fenofibrate in the US has a black box warning not to take it if you have liver disease. So
that's the legal voice. We know there's belt and braces.
Right. We still do it, but you have to make a very nice detailed chart note about informed consent. Keeps the sharks away. But fatigue to me, I mean, it's really, I asked the first question, how's your sleep cycle? And itching interrupts sleep interrupts and causes fatigue. So you want to fix the itching and you want to fix the sleep cycle. That gives people a lot more energy. And of course, coffee and tea are very healthy for the liver. We've found in many, many big studies that coffee and tea fight cancer. They're anti-inflammatory, they're anti-fibrotic. So coffee and tea in the morning, I think, are quite helpful. If you drink them later in the day, it makes your sleep cycle worse, probably. So I think working on itch, working on sleep, thinking about coffee and tea, some low dose caffeine can really help that energy level. What do you think, Collette? Is that a good combo?
I agree with that. I wanted to ask you, Bob. So I do love my coffee, but if I have it after noon, then that's it. I've got a sleepless night. Is decaf tea or coffee just as good, or
It's not the caffeine that helps the
Right.
liver. The caffeine helps the energy. There's
Excellent.
all these other healthy chemicals. It's a nice herbal treatment, so to speak, for the liver and the whole body.
Yeah, no, I do love my coffee. Now, I'm going to go into this fatigue thing because I feel pretty much an expert on fatigue, because I know of no doctor that can tell you why we get tired. And having had PBC and very, very, very ill with it, I don't think I was always as bright and sparky as I am now. In the early days, before there was any urso and just the way my pattern went, I've been through it all. And I really have. And I've had spells of fatigue. I could barely put one step in front of another. And I would go on to say, and you've probably heard this, Bob, it's not just sleepiness, tiredness, heavy limbs, lethargy. Just there isn't a word to describe it. I remember Professor Newberger came down with hepatitis, and he said himself there wasn't a word to describe this heaviness, this lethargy. But what we do know, what we absolutely do know, the last thing you do when you're tired is go to bed. You do not go to bed, you do not rest, because you're not going to help yourself in any way at all. We have this saying, we practice it, we preach it, we bang on about it. Movement is medicine, and it absolutely is. Now, I'm not telling you to get a gym and get into Lycra. I wouldn't fancy doing that. But we all have our own ways. We do a bit of gardening, we walk up the road, around the block, up and down the stairs. When you do something, you actually buy into more energy. You're never going to lose all your energy. You're just not. But the less you do, the less you're able. And the older you become too, we need to remember that our muscles, when you get into your 50s and 60s, they start to get weaker and smaller and disintegrate a bit. We've got to keep them, keep them on the move. They've got to serve us because we want to live to the 80s and 90s. So, do little things with a couple of tins of beans, or, bands, tying them to the bottom of a piece of furniture and doing a bit, as if you were rowing on the floor. Look up things on site. Talk to me. And all of us, we do things in the office. You can sit at your work and do things that can help you with your fatigue. I think people, and I fell into the same trap, when you're tired, it's too hard to do things. And what you don't realize, you're making it even harder for yourself. So I know of no one that's collapsed with movement as medicine. I know of no one. I don't believe in overdoing it. We've all got to pace ourselves. Because remember, we've got lives, some of us working, we might have animals, a sick relative, a house to keep, whatever. It has to be within the confines of our life and our domestic and working environment. But for me, that's the drug for fatigue at the moment until something else comes up. Do you want to add anything to that, Bob?
That's a fantastic formula. I love movement is medicine. I think that's very clever and right on the point. And people should look at other reasons they may not be sleeping well. The pain management you mentioned is really, really important. If pain's keeping you awake, work on treating that pain. And acetaminophen up to 2 grams a day is perfectly healthy or good for the liver. I mean, it's not bad. So acetaminophen, there's a lot of warnings about acetaminophen being bad for the liver at any dose. That's wrong. Up to 2 grams a day, perfectly safe.
Mm-hmm. And also, we've got some information, quite a bit of information on sleep. Before you go to bed, if you have a bath, a nice hot bath, with some candles and some salts, Epsom salts in the water. I don't know why they relax you, but they do. And they also help the itch as well for itchy people, because it is worse at night. So think about these things, but we do have some power. We can't necessarily control the run of the PBC, but we can make ourselves feel a bit better. And I tell you now, if you're able to do a bit of movement and medicine, a bit of walking, whatever you want to do, go around the house singing. I love 60s music, singing me to the Beach Boys and all these people. It helps you mentally and emotionally. And when you feel better upstairs, the rest of you goes along with it. Yes. And I'm very passionate about that.
Good. Thank you.
Okay, so now we've got Hillary saying, just to clarify, if ALP is not reducing within the first year, even 6 months, look at a second line medication. My own ALP is 131 after 8 months of urso. So that was coming from the question, which was further up, Bob.
So I would want to know for this patient what the alkaline phosphatase was at baseline before urso was started. If it started at 400 and went to 131, that's fantastic.
Yeah, it's brilliant.
If it started at 140 and went to 131, that's almost no change. So baseline, and I ask all my PBC patients, and actually all my patients with autoimmune liver disease, to map out on an Excel spreadsheet, because everybody's got a computer now, and everybody's got some type of place that they can log in their lab values and then look at them over time, especially as you do interventions. But one alkaline phosphatase of 131 is very close to 115. So I'm encouraged. And let's say they would say, oh, once 131, it's close to normal. I ask my patients to get an elastography once a year. And if the elastography is not getting worse or getting better, then you don't need to add a third medication or a second medication. So assessing fibrosis is really important to justify adding or not adding another medication.
Is the elastography, is that a fibroscan? Is that the same thing?
That's one way to measure elastography. We have 6 different tools. We have the EchoSense, this new company called Velicure. It's a Canadian company. They can do it elastography with MR, magnetic resonance machine, and then all the ultrasound companies, Philips, Siemens, and GE, have calculators or add-ons to calculate liver stiffness with their machines as well. So it's very easy to get elastography now. It's liver stiffness.
Liver stiffness. Okay. Right. So I'm going to my iPad here, and this is coming just now. So what could cause, this is a good question, what could cause a sudden jump in ALP, AST, and ALT? They tripled, had ultrasound, no fatty liver. Numbers were normal in November 2020 and tripled in January. Thank you.
So I always ask the patients, have they changed their diet? Have they changed their supplements? Have they started taking any new herbal remedies, any new prescription medicines? And they're taking Tylenol or acetaminophen. What's the dose they're on? How much alcohol they're drinking? You just got to look, globally, what's happening with the patient. And then PBC patients can get this overlap syndrome. And there is a concern that could occur even if someone's taking urso. They could have a breakthrough or an evolution or a change where autoimmune hepatitis comes in to the diagnosis. So those enzymes need to be rechecked again in another month. They keep going up, that person may need a liver biopsy, but a thorough medication, herbal supplement history is key.
I think it's important to say that something like crossover syndrome, and I think PBC, they can have crossover autoimmune hepatitis, as you've alluded to. And I think there are others, rarely PSC. There was something else I heard, I can't remember. But so there's, and also it's not just one set of blood tests as well. They look at trends. It's more helpful to do that because nothing very quickly normally happens.
Collette, did this person say that they had, they're getting, did they get an ultrasound right away? Because
no fatty liver, which was really good, which was encouraging, no fatty liver.
PBC patients do have an increased risk of gallstone disease and gallstones stone in the bile duct that can make those numbers really jump.
Yeah, that's a good point. I do know somebody who, everybody's story with PBC is interesting, and a lady who had this, had something similar happened, and they did an ultrasound, and there was no sign of any gallstones or any disease. But she was quite insistent, so they took her gallbladder out. And inside her gallbladder were 51 beautiful little black stones like jet. And they didn't show up on the scan. they were so beautiful, she kept them in a jar on her living room mantelpiece. But so sometimes it isn't always obvious what's going on, but that you do raise a good point. I mean, they used to say in the old days, clear fat and 40 was gallbladder disease, but people with PBC seem to be more prone, don't they?
I agree with you. Absolutely.
Yeah. Okay, so we're coming to another question here, which is it normal to get bouts of tiredness even though I'm taking medication as instructed?
The tiredness and the fatigue are cyclical, not related to medicines, not related to the liver tests. And I think it's an inflammatory process of the whole body that's affecting the brain. The brain is affected by inflammation, and the brain drives your energy level. It drives how you feel each day, how well you're thinking. Are you depressed? Are you happy? So treating inflammation eventually might help the brain. And these new medicines like Soldipar, they're doing a test for what are called patient-reported outcomes. How does the patient feel? Are they feeling better on treatment? And that actually will help the FDA or EMEA, other regulatory agencies, when they're looking about risk and benefit. And there's data with OCA, even though itching might be worse, that people feel better in general on treatment. So these medicines like OCA, I think, have an anti-inflammatory property that then helps the brain, that then helps the patient.
Yeah, it's a fantastic sort of picture when you listen to you say that. The FDA, to which Bob refers, is the Federal Drug Agency, isn't it, in America? And I'm speaking to them on I think it's either the 5th or the 8th of February, and I'll be talking to them about PBC, the symptoms, not so much the life-changing ones, but the ones that alter the quality of our life. And this is the kind of thing that I'll be raising, and of course the itch and other issues. So hopefully that can help people in America, get some of the help that they need over there. But the other thing I would say about this tiredness, if there's a sudden change, it's sudden, and you really don't feel that this is you, this is normal, tell your doctor, because we do get other things.
And what we say in the US, Collette, was we don't use the word doctor so much anymore. We use the word provider.
Oh, I see. I like doctor. Provider. Oh, well, aren't we all providers?
Well, it's true, but provider covers nurse practitioners, physician assistants, nurse specialists, pharmacists, although a lot of pharmacists are doctors now. So we've kind of switched over to be very inclusive of all the people that are on the team, and not just say the doctor is the only person. No, we've got a team of people. Right.
Well, I'm glad you told me. That's interesting, but my statement still stands. Tell your doctor, because your nurse can. In this country, a nurse can do blood tests. You have to get your GP, your doctor, to arrange that. So I will remember that terminology, and thank you for bringing that to my attention, Bob. Great to hear all these things. Now, my urso has been increased now to 1,000 milligrams per day. It was 500. Biopsy due blood results sky high. Consultant wondered if PBC now overlapping with autoimmune hepatitis. I'm not quite sure. I'm going to read it again. As it said, my urso has been increased now to 1,000 milligrams a day, and it was 500. And that is quite a jump. And I don't know what weight this person is. Blood results sky high. Consultant wondered if PBC now overlapping with autoimmune hepatitis. You must be a very small, light person if you were only taking 500 milligrams of urso. Now I'm going to show this to Bob. Bob, this is coming out. We're just about to launch this, and this is an urso calculator. It's on both sides, and it's in imperial and it's in metric, but for people to measure their own weight, and they can look at what they should be taking. Now, it is in the medicines box, but people tend not to look at it. Most people, when they go to a hospital, they get weighed, and a doctor will tell them what they should and shouldn't do. But these days, 2 years of COVID, doctors, providers being deployed into other departments, patients aren't being seen. So I think it's important we take charge of this. But for this person, who's saying you've gone from 500 to 1,000. The weight value here is important. There's no explanation as to why why doubling the dose.
Well, I think one thing, a lot of providers start with a lower dose because they want to be sure the patient's going to tolerate the urso.
Yeah.
And, there's our side effects. 8 to 10% of people can't tolerate urso for different reasons. So they'll start at a lower dose and then they'll double it after they make sure the patient's tolerated, or increase it after the patient has documented they're tolerating it. That's one thing. Sometimes they just miscalculate. They can just say, oh, I'm going to start 500. Then the next appointment, they look at the weight. They say, oh, you need to be on a higher dose. Or they read more. They listen to the PBC Foundation and say, oh, let's get them on the full dose.
Well, I have been so successful, and what have I lost? And you work in pounds, Bob. I've lost 45, 46 pounds.
Congratulations.
So I'm dropping my, and I'm very pleased to say so. I feel a lot better. So do keep an eye on your weight, but maybe just to clarify, if LP is not reducing from the first week, so let's look at the second. My own LP is, well, right, we've done that. So she's getting a scan in June. That's great. Okay, well, let us know how you get on. So next question is, about 6 months ago, my hepatologist told me I had compensated cirrhosis and portal hypertension, no varices. Is there any way to predict whether this will develop into the liver in future? So we've got, we're just getting these straight into Facebook, and I think there's words missed out here. So the hepatologist told you had compensated cirrhosis and portal hypertension, but no varices. So that's good. Is there any way to predict whether this will develop into the liver in future?
Well, I always ask myself or the patients to calculate the UK PBC score or Globe score, and that helps predict the future. But if a person has cirrhosis, that's already very serious. But the lack of varices on endoscopy means that it's early stage cirrhosis. That's extremely helpful, because PBC patients tend to get varices early, even with stage 3 disease, and this is obviously stage 4. But I'm going to ask the patient, I'm going to look at the labs, and I want to know the total bilirubin, and I want to know the direct bilirubin. Because in cirrhosis, the bilirubin is the best liver function test. And just to remind everybody, alkaline phosphatase is not a liver function test, in spite of some of the providers out there using the wrong terms. I call them bad terms. These are liver enzymes, but bilirubin, very useful. Total is good. Direct bilirubin, even better.
There was a time years ago, 100 years ago, when I was a young woman, the bilirubin, nobody spoke about the ALP in those days. It was the bilirubin. And they basically said to me, they watch the bilirubin and it moves up and down, just slightly. But over the years with PBC, before urso, even at the start of urso, it would slowly rise. But if they saw a jump in the bilirubin, a massive jump, that was what alerted the medics to the fact that this may be a candidate for a liver transplant. Now, because we have second and potentially third line treatments, we don't see as much of this these days. But Bob's quite right in what he's saying. The whole bilirubin is really important just to have a look at what that is, and they will be able to guide you. And if you're not at a transplant unit and you feel you're with maybe a gastroenterologist who hasn't got a full picture of PBC, ask to be transferred, because in this country it's allowed. You're allowed to do that. You can go to a big liver unit. If you don't know where they are, give me a shout. We'll let you know. Is that fair to say that about the bilirubin, Bob, and days gone by?
Yes. And I'm going to ask you, Collette, are you teaching patients about the MELD score and how the MELD score can help?
No, tell me about the MELD score. I'm going to write this down, Bob. I might be calling it something else, so don't disown me yet.
MELD score is model for end-stage liver disease. It was developed first by the people at the Mayo Clinic, Russ Wiesner and Patrick Kamath, and we use this MELD score every day to predict somebody's chance of being alive in 3 months or a year. Yeah. It's very, very accurate, and they use it for distributing organs for organ transplant throughout the world. It's very helpful because it's prognostic. So once somebody has cirrhosis, they should be watching their meld score. You can calculate it online very easily with the bilirubin, the coagulation test called an INR, and the creatinine, which is actually kidney function test, but the kidney is related to the liver function. So meld is, you may want to have even a discussion in their about that someday.
Yeah, I will. I'll take a note of it. I do know they do a life expectancy score, and it escapes me at the moment how that comes together. I have heard Professor Jones talk about this, but I will research it, Bob. Thank you for bringing that to my attention. I do know there's something of that nature going on, but the name meld doesn't mean a lot to me, so I will do my homework on that. Okay, so thank you. Okay, so here we go. Another couple of questions. I have been asked to do a drug trial for PBC. If my urso increased, does it work? It's called, well, it's OCA, a trial at Cambridge. Do you know of this drug? Well, yes, we do. We've talked about OCA and urso repeatedly over the course of this session today. So yes. So do direct your questions to the people who are conducting the trial. Because OCA has been licensed in this country maybe 5 years now. The foundation was instrumental, and it was one of the quicker drugs to be licensed. The company did their homework. They absolutely got this right, and it's there. So I'm not quite sure what this trial is about, or if it's a combination trial. So maybe a wee bit more information to the person asking that question. If you could send that, I'd be grateful. But it's nice to be asked to be involved in trials. Now, right, so this is a bit of a lengthy question. I was diagnosed with PBC, possible crest 4 years ago at the age of 40. FibroScan lab showed fibrosis 3 down to early 2 and fatty liver cured with 170 pounds weight loss. Fantastic. I've not been able to see a gastroenterologist doctor or tolerate urso. It gives her bladder pain and urinary retention. Finally, I had labs, all this normal range, including rheumatoid panel, inflammatory markers. Alkaline phosphatase is 118. One primary doctor says, with all labs normal, I'm fine to stay off urso and I'm in remission. Can we just stop right there? Nobody goes into remission with PBC. Nobody. It's just not possible. If you have PBC, you do not stop taking urso. Bob.
I agree with you that, I mean, there are people who are intolerant of urso, and that's the only time I would stop it. But urso is the foundation. And we say that PBC is uniformly progressive. But of course, in medicine, there's always exceptions. But where I'm going to say, I follow the 95% rule, is 95% of people with PBC will need a liver transplant or be at risk of dying of liver failure. There are rare cases, and I saw a patient this week. This is another interesting PBC-like picture. Person presents with what looked like fatty liver on ultrasound and a strongly positive anti-mitochondrial antibody. And this is the time to do a liver biopsy. Is it fatty liver? Is it PBC? Is it both? This person's liver biopsy was pure fatty liver. There was no signs of PBC anywhere on the biopsy, but a biopsy only samples 1/50,000th of the liver, right? So we could miss it. So I didn't tell this patient they did or didn't have PBC because I don't have tissue diagnosis. They have fatty liver for sure. We're going to lose weight, follow the enzymes, and decide in 1 year whether we're going to put them on urso, because we're going to do another FibroScan, another elastography, map out the course. But urso, people are on it. The enzymes are good. That means it's working. That means continue the urso. I agree with your global statement.
This person goes on to say that they're struggling to get insurance, so I take it it's possibly the States, it's not UK. And something that I don't understand why they've been a year's waiting list. Anyway, should I restart urso, and any tips to make it tolerable? I'm assuming this person's in the States or Canada. There's various companies that make urso. They all have the same compound, but what is different is the casing. It's the gel. that the capsule's made of. And sometimes it can be the gel or something in that capsule and not the urso itself that's causing you problems. We don't know. But also, there is something called suspension. You can have urso in liquid form. Now, it ain't nice. I can tell you, it's not nice, but it's there. It's worth having a try around. But unless you can't tolerate it at all, I mean, you just, PBC does not go into remission. It might stand still for a bit, but try and take your urso. I'm sorry I don't understand all of your question, but it does appear to be linked with insurance and things that I actually don't know anything about. But maybe if you want to rephrase that, and we can carry on with it next week or break it down a wee bit. And I hope you find that you're happy with the response to that.
Collette, should we talk for a moment about false positive AMA tests for a moment?
Yeah, let's do that. Yeah.
So this is some of the, the great, let's say, PBC teachers that I have, like Cynthia Levy in Florida, just wonderful. She's highlighted that the AMA test has changed over the years. Maybe 10 or 15 years ago, it was really rare to have a false positive AMA test. But more recently, as they've changed it, it's become more sensitive. It's picking up more patients. But now we're picking up AMA positive in patients who don't have liver disease currently. And it's not even clear that means that they will develop in the future. Now, this false positive, meaning it's a positive test, but there's no disease, might be in 3 or 4 or 5% of patients. So, and why people order it and people with normal liver tests, I don't know. Or they order it and they find, like this patient I saw this week just had fatty liver. So it's basically a flag. And if someone has a positive AMA but no liver disease, they just need to be checked every year. And I think these people will develop PBC 5, 10, or 15 in the future. That's personal expert opinion. So just be careful that an AMA is not, positive AMA is not a death sentence. It's not a sentence saying that you will develop cirrhosis or you will develop PBC.
So you wouldn't put somebody on urso on a positive AMA with normal liver function. You would wait to see what changed and then you would treat. No, that's perfectly reasonable. Somebody says, what makes the alkaline phosphatase go down? Mine is 141. Well, without more information, that's quite a bit. Medication would make your alkaline phosphatase come down, wouldn't it, Bob?
It's possible. And I just want to highlight the difference between liver enzymes and liver function. That you're first going to look at the enzymes because you're going to hopefully pick up people very early. Liver function, like bilirubin, won't change until relatively late. So really focus on the enzymes.
Yeah, the enzymes, not the fact. Now, you have pulled me on this before, and you're quite right. Does COVID-19 have an effect on blood test results? Well, this came up last week, and the response last week to that was basically lots of things can affect your blood results, but as it passes through your body, things return to normal. What would you say to that?
Well, the liver is a bystander in coronavirus infections, and it's depending on what your numbers are, but up to 50% of patients with corona infection can have elevated liver enzymes. It's only about 4 or 5% that have abnormal function, such as bilirubin. But the liver can get hit by coronavirus, absolutely.
And a common cold, I'm sure. Well, COVID is part of that family. Right. Well, I'm going to dash through this. I'm not sure how many we've got. Following on from your comment here, so mine was 801. I'm sure mine was 801. I'm not sure what was it in June 2020, and 254 in October. So the next test is going to be in a couple of weeks. Would this be a good response? Stage 4, according to the FibroScan.
So the first alkaline phosphatase was over 800, is that right?
Yeah, just over 801, yeah.
What's the second number?
254.
Okay, so that's an excellent response, but not an ideal response. We want that alk phos normal, but I'm very encouraged, and I would continue to look at that, and hopefully at the next test it will come down even further.
Okay, I'm going to hammer through these now. I have the start of cirrhosis. How long before it gets worse since having it? I'm totally worn out more than before. I mean, cirrhosis could go on 20 years, can't it?
Sure can. And that's where liver function comes into, importance. Do people have varices? How's their brain working? Is there any fluid around the intestines called ascites? I would want to know some more detail, and then we can stage that meld scores. Once people have cirrhosis, you start looking at the meld score. The bottom number is 6 and the top number is 40. And if someone has cirrhosis and the meld is 6, that's a really good number to have, meaning an excellent prognosis.
Yeah. Okay. What's the name of the most complete fiber scan, and how often do we need it? I live in Mexico City.
So the complete fiber scan, I think I understand that, basically involves both the stiffness and the CAP score for fat. And I usually do them once a year in my PBC patients. I never do it more often than once a year, because it takes a while to see a change or be confident that there's no change.
Okay. I have horrible long bone pain, mostly femur. Can this pain be PBC related symptoms?
I think we ought to highlight the need in all PBC patients, even in men, to get a DEXA scan. And the DEXA scan determines bone health. It's a very, very simple test to do, involves a minimal amount of x-ray. And bone health, osteoporosis, osteopenia, I think is associated with different types of bone pain. Vitamin D deficiency, very, very common. People who are vitamin D deficient can have bone pain. So everybody's vitamin D level, in my opinion, should be 40 to 50. If you really want to get on 4,000 or 5,000 units a day or 50,000 a week, are you advising all your patients about vitamin D?
It comes up every week because maybe we're in Northern Hemisphere and living in Scotland, we don't get as much sunlight. So yes, this is really important because it comes up with the COVID question as well too, doesn't it?
It's vitamin D, we think, modifies the corona infection. So people use a lot of sunscreen. They're not drinking as much milk products, which has a lot of vitamin D. And there's a sunlight issue. So every day I'm taking my calcium pills or drinking oat milk and with vitamin D, and I want my level above 40. So that's my personal opinion and what I try to apply to all my patients.
No, that's great. We've still got a couple more. Are you okay to go on, or are you time?
No, things are good. Let's go for a couple more minutes.
Oh, let's go. Right. I understand the source of my inflammation hasn't been found yet. This is this earlier person. I'm not sure which. Does the trail stop there, or is more investigation possible? Well, we don't know what investigations you've had. That's something you have to ask your own practitioner or a provider. Because we don't know, we only know so much, so I don't know we can answer that, Bob, really.
You have in the bare facts on your website what a basic, meaning full workup is, and I think that's useful for people who have these questions to make sure they refer back to your great website.
Yeah, thank you. The one we're just about to revamp. I'm wondering if PBC affects hormones.
Well, you'd say it might accelerate menopause because it is an inflammatory condition in women. I believe there's data that PBC might affect fertility, and if it's affecting fertility, it might be because of hormonal interactions. But I don't have a lot of data on estrogen or progesterone or testosterone levels. But once people get cirrhosis, hormones can really get disrupted or messed up.
Well, this leads on to the next question. I get terrible hot flushes and night sweats. Are these related to PBC, and how? But again, other things can give you night sweats, thyroid disease, various things. So you really got to go to your provider, your doctor, whoever, and give them the full list. Last question. Is there any way of checking the liver other than an MRI? And I get little bruises on my body. Does this anything to do with PBC? Thank you.
Well, imaging the liver can be ultrasound, CT, or MR, and they both have their benefits and risks. So it's very important. And then we talked about this elastography tool and CAP. We have a lot of ways to take a look at the liver without going in with a biopsy. There is something called the multi-scan that was developed in Oxford. It's a new type of MR imaging that tells us about inflammation. And I think this is for the future, Collette, because all of my PBC and autoimmune patients, I will be doing this special MR scan called a multi-scan every 1 to 3 years, because it measures directly inflammation in the liver through what's called a corrected T1, a CT1. And this will decrease our need for liver biopsies in patients even more.
Which I'm a big fan of. I've never had a biopsy, Bob.
It's okay.
No, I didn't get to ask my question, which is a lengthy answer, but I'm very interested. You touched on it, talking about vitamins, but I was very interested in what you spoke about food and meat and various things, PBC. Next time we might cover that, Bob, because we get asked these things a lot, and I don't want to answer on your behalf, but as a patient, I was very interested in any good news or help I receive from any doctor. I just like to spread the word to everybody else. So I'm first in line next time. Is that a deal, Bob?
It's a deal. It's a handshake. Appreciate it. Actually, it's not a handshake. It's a fist bump. Okay, got it.
Absolutely. So we've got to thank you. Very, very interesting. Looking forward to your thoughts. Yes, so you're going to write us something about fibre, which is fantastic. Thank you. Bob, you've answered absolutely loads and loads of questions, and you do it in such an easy, relaxed and friendly way. Great providers over in the States. I can't thank you enough for taking the time and getting up so early to join us. Alan, I know we've had a lot of people in. Thank you, Alan, Linda and Chris. They're all in the background doing all this stuff to make this thing happen. But I hope all stays well with you, Bob, and you keep with us. Working away in the PBC. I'll investigate the meld score. Okay, I'll go and talk to Dave about that, and James.
Yeah, thank you both. Another wonderful session, very informative. So I think, Dr. Gish, we've got you back in March sometime. I think it's near the end of March. Might be wrong there, but next week we're back on at 2 o'clock with Dr. Vino Hegarty.
Oh, lovely.
So everybody who joined in today, whether it be ClickMeter or Facebook, thank you very much for attending, and we hope you find it informative. So thank you very much both.
All the best, Bob.
Facebook.
I'll see you over here sometime, Bob.